Hello, everyone, and welcome to Occupational Therapy 226. Today's topic is the first of three presentations about conditions of infancy and childhood. And today we're going to be looking at medical conditions of infancy and childhood. My name is Melisa Kaye. I'll be your instructor. Let's go ahead and get started. This is part one of a three-part lecture, and we'll move through it just as quick as we can. We have two objectives for today. One is to explore some of the many medical conditions of infancy and childhood. So I'm not going to be able to cover everything that happens to kids. I'll cover some of the more common and more prevalent conditions, and also the things that occupational therapists tend to see. Now, the expectation is that as you learn about conditions, you're also going to be learning about how to get information and research conditions on your own so that you can gather some of this information yourself. But this will be a really great foundation, I hope. The second objective is to explain potential functional deficits arising from these conditions. So we look at the conditions, but then we need to pair it with what's happening with a particular child. So that's also very important, is that integration and synthesis. We're going to start off with prematurity and associated conditions. As you probably are aware, prematurity is when a baby is born before 38 weeks of gestational age. So typically we say a baby is due at 40 weeks. If they're born a couple weeks early, they're not considered premature, but anything before 38 weeks is considered premature. And gestational age simply means how long has the baby been inside the womb. It can be associated with or caused by a wide range of medical conditions, and the long-term outcomes vary not only by what condition might have caused it, but also very greatly by how premature a baby has been born. So let's first talk about gestational age, which can be measured from a woman's last menstrual period or by an ultrasound. So it's the total amount of time in utero from the moment of conception until birth. It's often not accurate, and so that's why there's that range of 2 weeks. A full-term pregnancy is 38 to 42 weeks gestational age. Premature or preterm is before 38 weeks. Late preterm is 34 to 37. Postterm is after 42 weeks. And 24 weeks gestational age is the low end of viability. So I've been in practice for 20 years, and when I started, we were looking at like 28, 29 weeks as the low end of survivability. So we've actually, as we've moved forward with medical advancements, that age has gone down. In this picture, you can see a premature infant who is in a neonatal ICU unit. And as you can see, there is a lot going on medically to keep this child alive. In one of our other lectures, we looked at correcting age for prematurity, and how we do that is we take the child's chronological age, which is their age from the day of their birth. Then we combine it with the length of prematurity, and we typically correct for gestational age up until a child is 2 years old. Now, for the purposes of assessment, which is where we learned that process of correcting for gestational age and also figuring out chronological age, we know that depending on the reason that you're correcting, say it's for a particular assessment instrument, we may vary that number of 2 years, but typically 2 years. So babies are designated by size and weight. So appropriate for gestational age is between the 10th and the 90th percentile. And you'll often hear about kids who are in the 50th percentile or in the 95th percentile for size and weight. If you're small, you're less than the 10th percentile. And if you're large, you're over the 90th. We also characterize premature infants by birth weights. So we have low, very low, ultra low, extremely low, and ultra low. And in the presenter notes, which you should be accessing throughout this presentation and for your studies, you can see the all of the designations, just as a point of understanding this. Ultra low birth weight is below 750 grams or below 1.6 pounds. So just literally a handful of baby. All right, so these slides are numbered, so you can kind of keep them sorted. We're in the topic of prematurity, and now we're looking at common medical conditions that are associated with prematurity. The first is a range of neurological issues, intracranial hemorrhage, in other words, a bleed in the brain, interventricular hemorrhage, which would be a bleed that is in one of the ventricles, and retinopathy of prematurity. So retinopathy of prematurity, or ROP, is a maladaptive growth of blood cells in the retina. So we have issues neurologically with children who are born quite early because of hemorrhaging, but also problems potentially with vision. Our second slide of common medical conditions associated with prematurity is respiratory conditions. And there are 3 of these, and you can see some visual displays of what alveoli look like normally and then what they look like when they're collapsed. So we're looking at the inside of the lung, right? So respiratory distress syndrome is one of the conditions. Bronchopulmonary dysplasia is another, and apnea of prematurity, in other words, a failure to breathe on a totally regular basis, but one that's associated with being premature, is another. So, what we find is that the lungs are one of the last organs to develop before a child is born when they're at term, and so pulmonary issues in prematurity are very common because the lungs tend not to be fully developed. This is the third slide of common medical conditions, and hyperbilirubinemia, also known as jaundice, is one of those conditions, and this is an excess of bile that builds up. It happens in premature infants. They wind up looking yellow, and one of the treatments is what you see in this image, which is treating the baby with light, so light therapy. And as you can see, the baby's eyes are protected, but they're being treated. So jaundice is an issue, and often if a child is a little bit premature, they might have some jaundice, but it corrects on its own. What we're talking about is jaundice that leads to anemia or other more serious health conditions. A couple other conditions are gastrointestinal in nature, gastrointestinal reflux, or GER. I'm going to just change this. So in other words, after the baby eats, they bring back up their breast milk or formula and have trouble keeping it down. And then necrotizing enterocolitis. So necrotizing meaning the death of cells, and enterocolitis meaning an inflammation in the digestive system. So that's another issue that we might see with babies that are born premature. As if that wasn't enough, there's a range of other conditions and complications that are associated with prematurity. They include hydrocephalus, which is, as you can see from this image, a collection of fluid around the brain. And this, in this diagram, the child has had a shunt inserted, which is a flexible tube that goes up to that intracranial space and helps drain off that fluid and send it back into the abdomen where it can be absorbed. Cerebral palsy is commonly associated with prematurity as well as other neurological issues, but in pediatric OT, we tend to see a lot of children with cerebral palsy, and we'll talk about that later on in this video series. Also, vision and hearing problems, anemia, learning disabilities, and that is diagnosed much later in a child's life, but there is a correlation there, and also developmental delay. In other words, a failure to develop in a typical fashion. Now, we used to say developmental delay, and people would think that the child would catch up because they were simply delayed. But developmental delay is a term that's used for a variety of conditions that will accompany a child throughout their life. And the term that we use for a child who has cognitive delays in particular now is intellectual disability. All right, throughout this video series, you will find these blue slides, which are a preparation for class. They're thought questions, so you don't have to write down your answer. You don't have to write your answers anywhere online or turn them in. But I would very strongly encourage you to write them down somewhere, just some notes. So here's the situation, and we will be discussing it in class, and the expectation is that you'll be ready to do that. If you were treating a 3-year-old who was born prematurely, why would knowing about this medical history be important to your treatment plan? So, in other words, why, what's up with all of these other medical conditions, and why is it important to know about them? The other part of the question is, what might you expect to see? So, to answer this question, you want to think about the domains of development, right? So occupations, yes, but also the domains, which I would say would be physical, including motor and sensory, communication, including receptive and expressive, social, adaptive, which includes ADLs, IADLs, self-regulation, cognitive, emotional. Sometimes that's with social emotional. So a range of domains, and I will put the domains in the presenter notes for you. So think about what you might expect to see and why. And obviously this case study is very brief, overly brief, right? It's just to get you thinking, as the title says, about what could be up with a child. Next up is teratogens, fetal alcohol syndrome, abbreviated FAS, and drug exposure. We're not going to get into a lot of depth about this, and we could for sure, but it's really important to know that a range of teratogens, which basically mean toxic agents of many different types, can and will affect a fetus and can result in some pretty intense conditions. So alcohol consumption in any amount at any time during pregnancy is unsafe. Fetal alcohol syndrome, or a step down from that, which would be signs and symptoms of fetal alcohol syndrome, can be an issue, and that includes orthopedic issues, attention deficits, problems with intellectual disability. So the child with FAS may be low intellectual ability or intellectually disabled. Children without severe or multiple symptoms are termed fetal alcohol effects, or FAE. Also drugs. So women need to be very cautious about all types of drugs, both prescription and non. Street drugs are 100% should be off the table, and cocaine and opiates are addictive, and so they're addictive for the child, and babies that are born drug addicted have a range of issues that can accompany them into later life. Attention issues, self-regulation issues, learning disabilities, things like that. Also, children who are born drug addicted or drug influenced tend to be small for gestational age, so they tend to be littler kids. Prescription and over-the-counter drugs, however, can also be problematic. And one example of this would be a woman who might be taking an antidepressant, gets pregnant, and needs to consult with her doctor to determine whether or not she should stay on that medication. Other psychotropic medications, same thing. And also some medications that are intended for physical issues. Caffeine and nicotine are also problematic, and then we go into a range of non-consumed, kind of drugs, alcohol, and other stuff that you put in your body, but they're equally harmful and dangerous for the fetus and the young child. So pesticides, radiation, chemicals, toxoplasma, and a range of bacteria and viruses. So we have a lot of different things that can affect the fetus and harm both the fetus short and long term, as well as potentially the mother. That brings us to the end of part 1, and I'll see you real soon for part 2 of Conditions 1 lecture for 226.